left one question for you that appeared beforehand. Shankar is asking, what's the maximum accuracy that you get for hand movement classification with EEG and also with ECoG? Maybe you can explain that a bit.
So for hand movement classification, the question is always, what do we want to classify? So for example, a resting condition against a movement condition. And in that case, of course, so we have to understand which features we can utilize. So in the EEG, that's most likely a low frequency band mu suppression in the oscillation, and in the intracranial recording, it's a high gamma augmentation, so high gamma activity. And this is not visible in the EEG, but it has a much better signal to noise ratio and is a much better feature. So that means in intracranial recordings, when we cover the motor cortex, then we can measure with 100% accuracy almost if the patient contributes nicely to the task, and we can detect it within like 300 to 500 milliseconds. So usually when we have the same experiment with surface EEG, then we can also reach quite high accuracy, but sometimes this is a bit disturbed, for example, by movement artifacts, by noise and so on. So it's possible, depending on the patient and the signal quality, to be somewhere in the range of like 80–90%, but it's a bit slower, and also we have to be sure, for example, that we are continuously holding the mu suppression over, let's say, a few hundred milliseconds up to 1 to 2 seconds, so it's a bit slower.
So Kapi is leading our invasive department here. Together with his team, he's developing very nice techniques, and now he's making a more practical session so that you can see how all these things are handled. Very nice to have you, Kapi. Thanks for waking up so early, and please go ahead.
Thank you very much. So today's session is about running functional mapping procedures in real time with high gamma and ultra high gamma biomarkers. So basically we are now diving into functional brain mapping with cortiQ, our passive functional mapping system, and how to use it, and the results and studies that we obtained already. So now the indication here is basically to preserve functional tissue during a resective brain surgery. So here you have, for example, the treatment of brain tumors when you have to remove them, and epilepsy when you want to resect the seizure onset zone, so that at the end the origin of the seizures can be like terminated and removed, and then after the surgery the patients can be seizure free. And when approaching those pathological tissues, then we have to be very careful that we are not damaging the physiological tissue that is still required for body functions, like here we have it shown as a list: the motor area, the somatosensory area, the expressive language area, the auditory cortex, receptive language area, visual cortex, and the whole visual categorization areas, like the fusiform face area, or on the left side the word form area, color perception, shape and object recognition, and so on. So it's very important to understand how this is distributed and localized in each individual patient to do an individual guidance of the surgical procedure. So what methods do we have of choice? So here already the high gamma mapping with electrocorticography or stereo EEG, in principle, in theory also with surface EEG, but it's very difficult to obtain high gamma features from the surface EEG. That's why, for example, for hand movement, we have to use the low frequency band mu suppression. But this is an observational biomarker, so we can observe while a person is doing something, like talking or moving, we can observe what is going on in the brain based on the distribution and the intensity of this electrophysiological biomarker. In contrast, there are also hemodynamic biomarkers. So we have, for example, the bold response in the fMRI, but also metabolistic changes, for example, in the PET. And with that, we can also observe indirectly brain activity based on the changes of for example, the blood flow and or the concentration in the blood. And then in contrast, we have the inhibitory and excitatory techniques, and here we have the electrical cortical stimulation and the transcranial magnetic stimulation, and of course also the WADA test, where in here one part of the brain is sedated with an anesthetic drug that is actually injected in the arterial carotis, and by that, for example, we can understand the language lateralization. So, for example, when you're left-sided with your language, then if the left hemisphere is sedated, then you get the speech arrest during this WADA test. And on the other side, for example, you can still talk. For electrical cortical stimulation, it's a similar effect, but more focal. So we can stimulate implanted electrode pairs in a bipolar manner. And then when we stimulate parts of the brain during a task, for example, during talking, then we can observe that this speech or the ability to talk can be suppressed by the cortical stimulation. And this shows us a simulation of a lesion in case we would have resected this part of the brain. So this is a very nice guidance tool just prior to the resection, and it can also be applied interoperatively through the progress of the resection with an handheld probe, for example. And then we have an excitatory phenomenon as well when we stimulate the brain. So it can happen that if we stimulate the motor cortex, then some parts of the body start to move. And it's very important to understand the distribution of the involved network, but also to pinpoint those sufficient or necessary areas by the stimulation. So now let's get the feeling of the intensity of the biomarkers that we want to utilize for the mapping, and let's start with the BOLD response. And here we can see the blood oxygen level dependency changes here between a resting condition and a movement condition, here a grasping task. And this is a block design paradigm. So this is 20 seconds of rest and 20 seconds of movement repeated 3 times. And then we have enough data for the MRI scans when we, for example, now perform between the slices from rest condition and the slices from active condition for each voxel at t-test, then we can understand whether or not there are significant changes in the deoxygenized hemoglobin in the blood concentration. And here we can see so that the task-related changes of the BOLD signal are approximately 0.5 to 5%, so relatively low, and that's why it's a bit difficult and critical to apply proper statistics to get really a nice significant activation and to repeat or have a high repeatability across subjects and between different software platforms that can actually process the fMRI. On the other hand, it's also a bit difficult because you need to have technical experts, and it's quite expensive to do it. But of course, the biggest benefit here is that it's a non-invasive mapping method that can be utilized actually before any implantation. So this is why it's widely used in neuroscience research and in pre-surgical evaluation. But of course, we have to understand what are the pitfalls and difficulties here. In contrast, when we look at the intracranial recordings, then we get the electrophysiological high-gamma activity marker. And here we can see now from this motor electrode, when we look at the biomarker behavior over time for different conditions, then we can see here, this is a baseline task 1, where the patient is basically sitting relaxed. And then we can see the patient in the active task 1 is solving a Rubik's Cube. And in here, the biomarker just jumps a lot, and we can see relative changes go even beyond 500%. So this is a very huge deflection. And then after the task, immediately the biomarker turns silent again. So here's another task where there's a partial contribution in the activation, but that also diminishes after the onset. So the majority of the time, this biomarker is pretty silent, but only during the desired during a specific movement, we can see that here on the motor cortex, this is highly active. So this makes us confident that these task-related changes can be clearly visualized on the brain. So what's the physiological response here? So for example, when we now record the brain signals from a certain part of the brain, here the cortex, then we get our voltage signals and against ground, and then when we plot it as a resting spectrum, when the patient is doing nothing, we get here this 1/f curve. So the decay of the power spectral density depending on the frequency. And now when the patient performs a hand movement task, at the time of the movement, we can actually see a change in the spectrum. So also slightly before the movement, but majority during the movement. And then we can see here that there are various multiple changes in the spectrum. And now when we overlap the two spectra, we can see a low frequency band suppression and a high frequency band lift. So it's very interesting now that this low frequency band suppression, like the mu suppression, which is also visible in EEG, is here widely spread on the cortex. And so we cannot really pinpoint now which part of the brain actually is now involved in the movement based on the low frequency band suppression. However, when we look at the high frequency band, starting usually at mains frequency between 50 and 60 Hertz, then we can see a very broadband increase in power. And this tells us that there is some, like a random process going on that lifts the whole spectrum. And so since already more than 25 years, many studies have reported this phenomenon, and it's now known to be like related to neural firing rate underneath the electrode. And with this marker for activation, now when we look at the high frequency band changes in the brain, we can see that this is now pinpointing to a specific location in the cortex that changes during the movement. And interestingly, this co-localizes, of course, with the low frequency band that we can see in the spectrum. So it's within the suppression area, but it's a much smaller region. So with this, we can really localize the hotspot of the body task or the movement. So now let's do this for many electrodes in parallel and perform a block design task resting pair like in the fMRI. So here we have the incoming data, and now we can see one brain map for tongue against rest, for listening against rest, and for Rubik's Cube against rest. And here we can now see when the patient is instructed to stick out the tongue, he is doing it. And then first we have the visual activation in the ventral temporal cortex. Here the primary motor activation of the tongue, and also an activation of the anterior temporal tip. Then again the patient is going to a resting task, and now he's listening to a Japanese story, and we have here again the visual activation first, and then focusing on the superior temporal gyrus, here indicating the auditory activation on the brain. And we can also see that on the patient-specific brain here in 3D. So here in yellow we have the tongue activation, and in blue the listening activation. And now the patient is solving a Rubik's Cube, which very much activates the finger movement area. So now here we can see this is the hotspot for the hand movement, and this is just a bit more superior compared to the tongue. So this nicely fits the homunculus anatomical structure. You can also see that there is also a suppression, an activation in the anterior temporal lobe, but this is basically dominated by the tongue movement later. So now we repeat it a second time, just to be sure to accumulate enough data. So in principle, what we need is 12 seconds of resting condition and 12 seconds of active condition to have enough data for the statistics. And of course, this has to be perfect then. And the patient cannot always perfectly follow the task instruction, and we don't want to rely on any outliers. That's why we repeat the task usually 3 times, and then we are confident that the result is robust and not caused by an external transient event that happened. So now we have the second iteration here, and now we can see that the brain maps don't really change, but they just get more focal and showing a much clearer activation over time. So now there is no change anymore. So what steps do we have to do in order to get this this brain map? So first we have to make sure that we get the zero mean signal. So in our case the amplifier is DC coupled, which is very nice because we can also measure, for example, slow cortical drifts. But for the purpose of the functional mapping, we want to get rid of this DC offset. So in order to do that, we apply a high-pass filter, and then we get here this zero mean signal, as you are probably used to it when you observe EEG or intracranial EEG recordings. Then we have to be sure that our signals are good, so that we can re-reference them and not contaminate the signal, for example, that we want to process. So very important here is that, for example, for bad contacts, we actually can see, probably due to the high impedance, that there is a much stronger 60 or 50 hertz interference in those loose contacts or in bad contacts. And that's how we can identify them quite easily. So we have to exclude them to not spread the 50 or 60 hertz interference into the good connected channels. On the other hand, we can also observe, for example, interictal spikes. And here, if they occur uniformly over time, the same amount in the baseline and active condition, they are not really a problem. So we can still map those channels that are affected by the interictal spikes. We just have to make sure that we accumulate enough data and that they are not bursting, for example, in one event in a short duration when we have a very short mapping paradigm. Then they can of course contribute into the spectral changes, but in principle it's okay to have them in the signal. So when you have them in both in the baseline and active condition, the only thing that will happen is that they reduce the contrast. So the bubbles that you have seen become a bit smaller because they lift the spectrum for baseline and for active, but that's it. So there is no real problem in adding them to the signal. Then we have to re-reference our data, and for that purpose we utilize a common average reference on the good channels, and here we can remove a lot of the common signals that we don't want to utilize. For example, here it clears up the 50 hertz interference and then has a very nice signal quality. Then here we want to extract our band power feature. So for example, in a 60 hertz environment, we obtain 70 to 170 hertz bands, and then get one band power sample every 200 milliseconds, and then we get one gamma value for our statistical test. So this is similar to obtain a slice in the fMRI. We get a band power value every time slot. And then here you can see the concatenated band power over time for resting condition in red and for the task condition in blue. And you can see the two distributions of the power, and now when we test for the difference in the mean under consideration of the variance of the distribution, then we can now get significant changes in the brain. And our outcome metric to do that is actually the R-squared value, so the coefficient of determination, and it tells us the proportion of the variance in the signal that can be explained by the task. So the stronger this lift from the red to the blue is, the higher is the contribution and the higher is the R-squared value. So if now this, for example, would be very tiny in the variance, then we actually follow the step function of the paradigm that we have here in black. And this would be a perfect fit, and then we can show that on the brain. Yeah, and then we have to finally present the outcome metric on the topographical brain. And so here you can see the size of the bubble is actually corresponding to the R-squared value. And a physiological meaningful result is somewhere around 0.1 to 0.5 R-squared. In some cases it can get higher, but most of the physiological responses are in that range. And in order to get a significant value, we need to collect at least 12 seconds of data, so that an R-squared value of 0.1 can be considered as significant with a alpha of 0.05. So now that we have obtained our biomarker, how good is it for the indication that we discussed initially? So over the last 10 years, there have been or even longer, like 20 years, there have been a lot of functional outcome studies. And so first, of course, there's the group of Dr. Kojima with Asano's lab, and here they actually showed that 28% of the deficits were predicted by the ECoG biomarker alone, showing that the high gamma mapping significantly contributes to the functional outcome. So the surgery was done based on the ECS mapping result, but of course this is not perfect and there are some remaining deficits. And about 1/3 of the deficits can be predicted by the ECoG marker when we add that to the mapping pipeline. So there's the potential to reduce the number of deficits after the surgery even more. Then Arias group showed that there's a significant decrease in the working memory score after resecting ECoG language locations. Also Sonada showed an 80% language score decline were predicted by ECoG language locations. And more recent studies showed that there's a significant decrease in visual naming scores after resecting ECoG naming locations on the ventral temporal lobe. And also very interesting is that just a recent study from Tan et al., so this is a group in Oregon, they actually showed that there's a significant longer overall survival rate after glioma resection when adding the ECoG biomarker to the mapping procedure compared to ECS alone. And then we already saw from 8 independent studies that the resection of ECoG positive language or motor locations, which were ECS negative, also caused deficits after the surgery. So all of this indicates that there's a strong need to further improve the functional mapping in the state of the art. And by adding the high gamma activity as a biomarker for functional mapping, we can actually achieve that. So how can we now incorporate that into a clinical environment? So the system has to be automated and quantitative, intuitive, used by a clinician. It should be portable so that we can use it at the bedside, for example in the epilepsy monitoring unit and in the operating room. It has to provide results in real time so that we can make decisions immediately, and it should not require any complex medical imaging, for example co-registration and so on, that may block the procedure. So it's of course possible to add this information, but it shouldn't be mandatory. And we realize this in the cortiQ that actually consists of a biosignal amplifier, the connection to the electrodes via the headbox, the control computer with the software that analyzes the signals and shows the output, and also the patient monitor that actually instructs the patient for the progress of the functional mapping. And this is FDA cleared and CE certified, and also certified in other countries like Australia, Israel, and Canada. And we can actually use it similar to fMRI to make statistics between task-related changes, and that showed it topographically for then further contributing to the guidance of the surgery. And there are two use cases for surgery or for planning the surgery. So one is the awake surgery case that often happens, for example, for glioma surgeries, where we have a one-stage surgery, and if it's expected to be in an eloquent region, then we need, for example, an awake surgery where during the progress of the surgery, it's monitored whether or not there's a potential, for example, deficit in the speech when some areas of the brain are resected that are close to the language network. So for that purpose, we want to identify that before the resection, but during the surgery. And based on the lesion, we can identify approximately which regions are affected and design our tasks based on that region. And then we have the electrode implantation and the open craniotomy, and we can then localize our sensors, have the begin of the awake state after that, and perform the mapping with different modalities. So we can do the screening, for example, with the ECoG biomarker. We can stimulate after the ECoG mapping into the bubbles and see if we can actually elicit a speech arrest, and then continue with the resection and maybe repeat the monitoring occasionally, or observe during the resection if there is any deficit. Then we have the end of the awake state and see the surgical outcome. In the epilepsy monitoring unit, for example, this is slightly different. So here we have a two-stage surgery, and so after the first stage we already know our sensor location, and here we can also, for example, utilize T1 weighted pre-surgical MRI and the post-surgical CT to localize the sensors. And then based on the epilepsy monitoring, we can understand which areas in the brain are affected and then design our tasks to fit this monitoring outcome. And then we want to do the same procedure, so we perform mappings in many modalities, then have the surgical planning, and then the resection, which can be again an awake surgery. So how does this look? So first we have to create our montage. Like here, we can see during an awake surgery, we can make a picture of the craniotomy, add that into the software, the montage creator, and then overlay the exposed cortex with the connected electrodes with virtual grids. And then we can actually see on the craniotomy, on the photo, the brain activation. So here we have two grids, one on the motor cortex, and then we also need a distant electrode strip, for example, for ground and reference. It can also be that this strip is dural facing, so looking upwards, to not get contaminated with an unexpected brain activation. And then we get the channel assignment table for a proper connection. So there's another use case, of course, when we are going to the epilepsy monitoring. Then, for example, if we have stereo EEG implanted, then it's also possible to select the stereo EEG from the catalog. So there's a grid database coming with the cortiQ software, and all the big manufacturers that are used worldwide, including g.tec, Unique, PMT, Dixie, cortiQ, and so on, are added into this database so that you can select the electrodes that you have implanted. This is also important to calculate the charge density, for example, for stimulation. So it's also a safety feature. And now we can align the stereo EEG electrodes with the CT artifacts in the slices of the co-registered MRI and CT. So the slices have been just added as a background image beforehand, and then we can nicely overlay them with the CT artifact so that we can see which spot in the brain is getting active during the mapping. And then again we get this channel assignment table. And then the next step is to perform, to create a paradigm, so a task. So assuming that we have a coverage of the language network, then we can think of a picture naming task. So in order to do that, we can now the paradigm editor, and here we can now select, for example, between 1 to 4 tasks. And here the baseline condition is now a symbol, so scrambled images that can be loaded from a folder on the PC. And now you can see we have a list of nonsense symbols, each presented for 3000 milliseconds or 3 seconds in a randomized order. And now in the active condition, we want to show meaningful objects. So we again import images from a folder. And then here we have a sequence of objects. So the presentation time is again 3 seconds, and we want to show in one block 7 images over a total period of 21 seconds. And each time the patient sees the object on the screen, they have to either express what they see, so name the object, or if it's can be more complex, they can also generate a verb, which is usually causing a strong activation, but is of course a more difficult task. Okay, so once the protocol is established, we can actually perform the mapping. So then for that purpose, we launch the main application and connect to the amplifier and the electrode. So now everything until now could be actually done without the contribution of the patient, either in the office or next to the patient, but without having the patient doing anything. So now we have to connect the electrodes, and now of course we have to be sure that the signal quality is good. So here we can see some electrodes with a bad contact causing a high 50 Hz interference. So we will exclude them from the mapping to not contaminate the signals that we want to analyze. Okay, and now that we confirmed that everything is clean, we can actually start the mapping. So here in the black box you can see the patient screen indicating that we are in the pre-run duration of 10 seconds. Now here we have the resting condition. So this is the Japanese symbol for rest. It's a kanji, it's a man standing next to a tree, taking a rest. And then we can see the upcoming first task is a kiss movement. So moving the lips repetitively. And then we can see first the visual activation and then gradually the focus on the primary motor cortex of the oral motor. Then we have the resting condition for the next task, which is tongue against rest. And then here we have now the visual activation, the anterior temporal lobe activation of the tongue movement as we have seen it in the patient before, and then the primary motor cortex of the tongue, which is just slightly inferior compared to the oral motor. So again, this is a nice match. Then again we have a Rubik's Cube, and first the activation on the visual cortex, and then gradually moving the activation to the primary motor cortex for the fingers and the hand. and we can perform up to 4 tasks, and here the 4th task is now a listening task. So this is again resting and then a Japanese story that we can hear.
昔々あるところにおじいさんとおばあさんが住んでいました。二人には子供がいなかったので、おじいさんとおばあさんは神様に
I will move over now. But in principle, after a few seconds, we can see that there are already good results if the patient contributes to the task, and then we just want to be sure that it stabilizes. So now we want to have a look at cortiQ studies that have been conducted in the operating room. So as you have seen in the montage before, now the patient is connected, and we can see when the patient performs now a grasping task, where is the center of the activation. And we can see here that this nicely fits with the hand motor area in the fMRI, and also hand movement related activation with the handheld probe. So this is direct cortical stimulation with a handheld probe and 2 bipolar pins. So here we can then, for example, stimulate an area, and here's the indication for speech arrest. And we performed this in a grasping task and also a picture naming task by slightly moving the grids. And we can see very strong activation also in the operating room. And interestingly is that the cortiQ mapping with different tasks took about 9 minutes per patient, and the cortical stimulation mapping took about 26 minutes per patient. So the cortiQ mapping turns out to be much faster for awake surgeries. It's also possible to do it under anesthesia. So another group in Japan from the John Tendu University actually showed that in this glioma case, there was actually a passive listening task under a BIS level of 70 to 90, so very mild sedation. And we can see that there is a significant change between word against sound, sound against silent, and word against silent. And here we can see the coverage of the grid. So here is the Sylvian Fisher, and so this is just crossing the border between the temporal lobe and the frontal lobe. And then we can also see, when we look at the dynamics, that after a few hundred milliseconds after the listening onset, we can see a positive deflection even for word against sound. So even this contrast can be visible. So now we want to understand how good the intraoperative mapping is compared to the epilepsy monitoring mapping, when the patient is of course in a different condition. And here at the Asakawa Medical University, together with Dr. Kamada and Dr. Ogawa, we tested a group of brain tumor cases and a group of epilepsy cases during a picture naming task, and compared it to the cortical stimulation. And actually it turned out that the awake surgery cases corresponded better to the cortical stimulation results, but not significant different to the epilepsy cases. So of course we need to collect more data to make a precise conclusion, but already the 2 cohorts show us that it's feasible to do the same task in the operating room and the epilepsy monitoring unit. This is a very nice study from Ahmed Raslan and Barry Oken together with Hao Tan, and here in Portland they showed after measuring already 47 cases with cortiQ that compared to stimulation mapping alone in a group of 28 cases, that there is a significant decrease in intraoperative seizures and a significant decrease of intraoperative seizure and a significant increase of the overall survival length in the patients that underwent the mapping. And very interesting is that actually the group where the cortiQ mapping was added had very negative prognostic factors, including a majority of male patients and also a majority of high-grade gliomas compared to the stimulation group alone. So that means although the clinical risk factors were higher for the cortiQ group, the survival rate was also higher. So this is a very good indication that we can here very much positively contribute to the surgical outcome. And also they added it into the suggestion for awake surgeries into the clinical routine, so that the protocol should include passive gamma mapping with cortiQ, cortical stimulation, and cognitive monitoring during resection. So then let's have a look in the epilepsy monitoring unit, how it is there. So here, of course, we can now utilize pre-surgical MRI and post-surgical CT to localize our sensors locations, and by that perform a more detailed analysis in regions of interest, and also merge the locations, for example, here in grouped studies on the MNI brain. And what is also very nice is that we can compare it directly with the fMRI activation and the ECS. So here you can see the projected fMRI onto the cortex, and then the localization of the positive electrodes, for example, for a face against object task, so a visual categorization task in fMRI. What is also important is that we have very strong artifacts here in the mid-anterior part of the temporal lobe due to the ear canals. So we are having a blind spot in the fMRI, which we don't have in the stimulation and the ECoG mapping group. And what is very good or nice is that we can see that the ECoG mapping is most sensitive, so it co-localizes with most of the phase selective regions with other modalities. So it's not only showing any activation, but co-localizing with other modalities together. ECS mapping shows positive results in all cases, but with the big artifacts in the ventral temporal lobe. And the cortical stimulation mapping was only sensitive in 2 out of 5 cases. So this is very subjective. So here we have to be very careful and understand if other biomarkers, for example, are more sensitive, that we also consider this in the decision-making process. So another site in the Boston Children's Hospital with Dr. Takioka, they already showed that language mapping is feasible with the stereo EEG, for example, for expressive and receptive language locations, also for more than 34 patients now. They investigated motor and sensory sites with stereo EEG, and when we look from this example from the Kindai University in Japan, we can actually see, based on the montage that we have created beforehand, when we perform a grasping task, how this can be also localized with the stereo EEG. So here now we can see a block of resting condition and a block of grasping condition, and now during the grasping we can already see this activation here in the medial side of the Rolandic cortex that is causing task-related movement activation. So now let's do this also in 3D and look at the dynamics. So in order to really understand where the electrodes are located, we have to now localize our sensors. And for this, we utilize our intracranial EEG montage creator that can import a free surfer output for the cortex and the brain volume segmentation. Then we can calculate the brain hull, and then we can actually do the co-registration with the CT. And once we have the co-registered CT, we get the segmented CT artifact at the same location as the brain. So now we can remove the CT artifact that is not, or that is actually caused by the cables and disturbing us, for further selecting the electrodes. And then we have the CT artifacts here as white blobs remaining. And then automatically the montage creator is assigning the shafts to the locations of the CT based on the orientation of the CT group. So this is all automatically done. And the only thing that we have to do is that we have now to assign the correct shaft that has been implanted from the database. And also we have to correct the position of the shaft along the trajectory so that we actually can now see that the CT artifact, the blob, and the electrode, the metal, perfectly match in their location. So here we can now snap the shaft to a trajectory, and then immediately it fits to the CT artifact. And now here we can see the electrode shape, and we can now move the electrode along the shaft so that we fit the CT artifact. And after that we actually get now the exact location of the electrode in the brain, and now we can look where this activation happens and when is the peak activation. So here we can see that approximately 400 to 500 milliseconds after the cue onset to perform the movement, we get this hotspot activation in those two electrodes. And now when we perform the mapping again in an event-related manner, then we can actually see how the biomarker follows the movement instruction. So here, of course, this is the cue. So this is not synchronized with the movement. That's why the brain activation comes a bit later with the actual movement. Okay, and now we can do the same doing a picture naming task. And now we can see here the event-related changes, so the high gamma dynamics over the time, where we first have the visual procedure when you see the light on her face, and then she is looking at the egg, the tamago, and then she is having the activation here in the expressive language area, and then finally, after the overt picture naming, here also in the anterior temporal, the oral activation. So now when we want to compare this and to do it together with the cortical stimulation, then we can actually, so we'll jump over here, then we can actually see how good, for example, stimulation responses can be co-localized with the hotspots of the high gamma mapping. And so now we want to actually combine the strength of the cortical stimulation with the passive high gamma mapping and stimulate directly into the bubbles in the next version of the cortiQ. So here we are now incorporating the switching unit so that we can then programmatically interact with the interested locations that show, for example, the high gamma activation in the cortical mapping, and then immediately switch to the sites that we then further stimulate with the eStim Pro, the cortical stimulator. So the cortiQ and the eStim Pro can be already used together, and now the next step is that we have this immersive integration together with the switching unit. And this looks like this. So we select the result from the cortiQ mapping that we have just seen. So here we can see the activation that happened during the picture naming for the expressive language sites, and then we can actually select programmatically the STIM plus and the STIM minus directly on the brain map and stimulate the brain, and then assign the related functional category for the stimulation related symptom and directly overlap and compare it with the high gamma mapping. And Dr. Kamada already showed us this. So when we, for example, now look at the high gamma dynamics and the response to the tamago, then we can see when we now stimulate at different times at the peak of the high gamma, then we can see that we can get, in this case, a transient aphasia, and when you hear the buzzer sound, she cannot say tamago anymore, but afterwards she can do it again. So that means that during the time of the stimulation, this ability was actually blocked. And we can see here that the chance to have this stimulation effect is higher before the high gamma peak, and this is not general. This is not like a fixed number. This varies from each subject. So some subjects are just faster, like this second subject, and also here this threshold of the high gamma peak nicely predicts the occurrence of the ECS related symptom. We showed that in another visual categorization paper where we actually stimulated into the hotspots of the phase preferred high gamma electrodes, where here you can see that there is only activation for phase percepts in the high gamma here in Z-scores over the time. And when we stimulate during the visual perception into those areas, then we get actually this visual phase illusion. And that also co-localizes with the cortical stimulation and high gamma movement. And the group from Nuri actually showed that we can have a very good overlap of the high frequency band, so the high gamma that we know, and the ultra high frequency band in 300 to 800 Hertz. And that actually, when we now compare that with the symptoms of the cortical stimulation, that we get a better overlap for higher frequencies with the stimulation. So here is the DCS plus side, and this ultra high gamma activation actually focuses on the DCS plus side. So this is a very interesting finding, and this is also something that makes us confident that this combined procedure is a very strong future functional mapping approach that we want to realize. And how is it possible to go that far? So even until 800 Hertz. This is because of the characteristics of the amplifier that we have here. So the amplifier is sampling at 614 kilohertz internally, and then downsampling to the desired sampling rate of 2400 Hertz, and by that increasing the signal to noise ratio. And this makes it possible to also get into very high frequency ranges and see task-related changes beyond the noise floor. And this is now the current status for our palette. So here we have the high gamma mapping with cortiQ and the cortical stimulation that can be already used together. And now the next step is to incorporate the switching unit into this combined cortiQ version 2, so that we can then utilize the strength of all the modalities, and by that provide the best and efficient, most efficient way to perform functional mapping. Thank you very much. So I hope you have time for questions.
Thank you very much for the nice presentation. Kapi, maybe you could go back to the mapping video that you just showed before. Yeah, this one. There's also a video where you can see temporal dynamics. So first of all, so the basic question is, when the red bubbles are appearing, is it Broca area or is it expressive motor region, you know, for saying the word? So these red bubbles now on electrodes, I think it's 16 and 20. Here. So is this motor or is this Broca?
So when we take the anatomical landmark, then we actually get it from the frontal lobe. So the electrode position is located on the frontal lobe and not on the
prefrontal,
central gyrus. Yeah, so it's not on the motor cortex. It's on the frontal, but it's very close. So and the symptom was actually here as a speech arrest. So in other locations, he also demonstrated dysarthria, which would be related to the oral motor.
And the bubble on the left, there's one single one which occurs just a moment earlier than the left one occurs first. The other two are coming afterwards.
So it was very interesting that actually here the cortical stimulation mapping was more silent, I think. And here we got the speech arrest. So this is kind of an associated electrode that actually first gets activated, and then we have here this kind of main activation, so to say. So it can be that this is more related to the actual planning but not affecting the ability to generate the speech. Whereas here we actually have the speech generation part, so we cannot talk anymore when we are stimulating in this part.
Next question is, what is the specific software for intracranial stereo EEG electrode location and co-registration with CT and MRI?
So this is the intracranial montage creator, and that is actually part of the g.tec suite. So everybody who has the g.tec suite can utilize the intracranial montage creator to register the CT and the MRI and create a 3D brain model out of that. And those 3D brain models can be then visualized either in MATLAB or in our HISUS toolbox or in cortiQ.
Then Karin is asking, is the software standalone or can it only be used with g.tec amplifiers? cortiQ.
So the cortiQ mapping that is certified, of course, has to be restricted because it's a combined system. So that contributes, or that consists of an amplifier and the software and the computer, and we have to guarantee that all the signal propagation and recording works. So that's why this bundle is restricted to only the high amp.
Then Crystal wants to know, why is there a polarity shift when you're doing the central sulcus mapping between the motor cortex and the sensory cortex?
I think you're referring now to median nerve stimulation, and here this is kind of the different connection to the peripheral nerve. So this is a somatosensory evoke potential from peripheral nerve stimulation, and actually we can see this reverse phase as a response of the nerve. It's not related to the high gamma activation.
Then Jan is asking, can you use ECoG, the ECoG electrodes and stimulation to stop seizures?
This is also possible. So there's actually already an approved method for that. It's from NeuroPace. It's responsive neurostimulation, and they're actually terminating the seizures. It can actually be done with grids or with stereo EEG, so it depends on how the implant is configured. But important is that it reads the intracranial EEG and then has its stimulation protocol to terminate the seizure.
And Crystal wants to know the facial recognition region. Is it on both hemispheres or only left or right?
So the most of the face activation actually happens on the right side. In contrast, for example, the word form areas mainly located on the left side. However, there's like one part of the network that is distributed on both hemispheres, and then a more specific part that in the majority is localized on the right side. So it's a mix, but more biased to the right.
Okay, Christoph, this was very nice. Thank you very much for waking up so early for us. All the best for your journey in the US.
Thank you. So actually, yeah, we are coming for a mapping the next couple of days. So let's do it.